Today we have Brid as our first speaker. She comes from Ireland. She got her Ph.D. at the University College of Dublin, and then she got a master's degree, and she came here to NCI, was working with Kurt Harris, and now she's an NCI Earl Statman tenure track investigator. Her title, Cancer Health Disparities. Brid.
Thanks very much, Terry. Thanks for the invitation back again this year to talk with you. If at any stage, if I'm going too fast or just anything like that, let me know. I'm recovering from a slight cold as well, so you know, if my voice isn't clear enough, just let me know and I'll slow down. I think everybody has colds these days from what I can see. So the lecture today sort of has two main parts to it. The first, of course, is to give a discussion of some of the key cancer health-related disparities that exist within the US. And then the second part of the talk, we're going to go into a little bit more detail about what some of the factors could be that contribute to these disparities. I want to say at the outset that we're not going to cover every single type of cancer in terms of disparities. As we go through and as you see examples, you see the specific cancer type shift a bit between, you know, lung to breast to prostate as we go through. And also, it just isn't possible to cover the breadth of science and literature and disciplines that contribute to cancer health disparities. So the lecture is more geared towards giving you a sense of what the state of the problem is and some of the approaches that are taken to try and address it, rather than be entirely comprehensive, because it's just not possible in an hour. I'd say as well, at any time, if you have questions, you know, just raise your hand and I'll try and address it. If I don't know the answer, and there's a lot of questions that I won't know the answers to, but if I don't, I'll pass you on to another, either another resource or another person. The last thing to say is, as Terry said, I'm an investigator here at NCI. My lab has been established for about 5 years now, and we study cancer health disparities, but primarily disparities related to the lung. So that's where probably most of my expertise would be in terms of research and the types of things that we do in the lab. But as I mentioned, you will see examples from other cancer types speckled throughout the talk. All right. A couple of the things to address from the outset. For the most part, you'll hear me talk about disparities, but I just wanted to emphasize that when we talk about disparities, we're talking about obviously race, but also ethnicity. And just at the forefront, just to set some definitions in place, just to give you how we are defining race and ethnicity in the context of this specific talk. So race will be biological differences between groups assumed to have different biogeographical ancestries or genetic makeup. Whereas ethnicity is more of a multi-dimensional construct which reflects biological factors, geographical origins, historical influences, shared customs, beliefs, and traditions among populations that may not have a common genetic origin. And it's important to note that both factors are important when we, in health disparities research, where we're trying to understand the causes of cancer health disparities, but also our efforts to diminish them and reduce them. So within the United States, many of you will know this already, but there are significant racial differences in life expectancy. The first of these, just to point out here, this is for Black men. And what it shows is that for Black men, on average, throughout the life course, they're expected to live about 6.5 years shorter than white men. And for women, there's a similar difference in life expectancy. And so research has been done to try and figure out what are the main contributing factors to these differences in life expectancy. And as you can imagine, cardiovascular disease is quite a big contributing factor in both men and women. But the second leading contributing factor and disparities between life expectancy between Black and white men and women within the United States is cancer. So the NCI defines cancer health disparities as differences in the incidence, the prevalence, the mortality, and the burden of cancer, and as adverse related health conditions that exist among specific populations within the United States. And it's been demonstrated now for quite a while that there is an excess burden of cancer within the African American community within the US. And this is a quote from the Irish Cancer Society, which states that African Americans have the highest death rates from all cancer sites combined and from malignancies of the lung, colon, rectum, breast, prostate, and the cervix, and that's of all racial groups in the United States. And what we're going to try and do today in the lecture is to maybe put some numbers behind and statistics behind that particular statement, and then to address some of the factors that could actually be contributing to it. So this is from JNCI from last year, and this is just looking at all types of cancer-related death, but just looking at the burden across race and stratified by gender. And what you can immediately see is that for all cancer types combined, in both men and in women, African Americans, Black individuals have an excess cancer-related mortality. The lowest can be found among Asian Pacific Island populations, and as you can see, as you go from Hispanic to white to non-Hispanic populations, you can see a range throughout. One of the other interesting observations that has been made is that in addition to having a higher burden of cancer types, what's also been found is that for many cancer types, not all, but for many, the age at which these cancers are diagnosed tends to be younger in populations of African descent. So this is work by Hilary Robbins and Meredith Shields in DCEG. And what they've shown is that for many different types of cancer, the ones that are significant are shown here in black. There is a younger age of onset for many of these diseases. And as you can see, it includes prostate, lung, pancreas, and colon in women. And these are 4 of the main most lethal types of cancer. So you might wonder to yourself, well, why is there an earlier age of diagnosis, or what factors could contribute to this? So one of the possible factors is something that we call etiologic heterogeneity. So etiology basically refers to factors that can cause or are associated with a particular cancer. And it's possible that within an individual population, that the cause of cancer can vary between groups. The cancer could cause, the agent could cause cancer at a different time within that person's life, and different subtypes could also be caused by different factors. And then one example here would be in breast cancer. So we know there are various molecular subtypes related to estrogen receptor and the Herceptin receptor. And what we've known now is that these various, that there are various reproductive factors that are more associated with one type than another. So that's an example of where different exposures can affect different biology. And in breast cancer, which we'll touch on a little bit later, the triple negative breast cancer subtype is one that is more common in populations of African descent. Another factor that could lead to a different age of onset would be there could be a difference in the timing or the intensity of the exposure. And one example here is tobacco. So obviously tobacco causes not just lung cancer, but many different types of cancer. But the age at which you start smoking could actually have an effect later on in the age at which you develop the tumor. And we know that African Americans, for example, generally start smoking at a later age than European Americans. But we'll get into smoking in a little bit more detail later. And also there's, excuse me, there could be differences in the timing and the prevalence or the frequency of early cancer detection. And so here what we're talking a lot about is access and uptake of screening, so things like mammography, FOBT testing for colorectal cancer, and also now, thankfully, low-dose CT screening for lung. This particular area and this observation has led to the development of the NCI Early Onset Malignancy Initiative. And this is a group that are really trying to delve in deeper to fund resources and fund studies to really try and understand, or can we understand, what are the causes of these early onset tumors, and in doing so also come up with interventions so that we can try and diminish the disparity essentially. A lot of what we're going to talk about today is about primary cancers. When I say there's a higher burden of cancer across specific groups, we're primarily talking about first cancers. But there is now a burgeoning literature which is starting to look at the incidence of secondary cancers as well. And this is possible because thankfully more and more people are living and surviving after their primary cancer diagnosis. And this is one study from a former fellow here at the NCI, where she was looking at gynecological cancer and then within that population tracking to see what the incidence of second cancers was. And you can see that for both all sites, which is shown here, but also all the other major sites, there is an increased incidence of second primary cancers at these sites in Black women compared with white. So there isn't a ton of literature on this area, but it's starting to gain more and more attention. And it's as important as looking at as it is looking at the primary diagnosis. And this is just other work. There's 2 papers mentioned here that are definitely worth a look up. And what these papers have tried to do is over the last, we often give you statistics and numbers and we tell you this is what it's like now. But that's just a snapshot in time. And incidence rates are very dynamic and they have their own patterns and trends. And what people try and do is look to see at how that has changed over time. And while today it is true that African Americans have the highest cancer-specific mortality, the racial differences, in some cases, they have been reducing over time, which is certainly good news. In some cases, like breast cancer, there's actually evidence that the disparities might be increasing, and that's in terms of mortality, and there are things that need to be tracked. So we're going to look at some potential factors that could contribute to cancer health disparities. So the first of these, and one that's extremely important and isn't so much related to biology as it is just a lack of early detection. So every year in about January, there's this paper put out by our colleagues at the American Cancer Society, and they list all the different types of cancer and what the incidence and what the mortality is. But one of the figures that they always include in their paper is the stage at presentation. And this is just an example from 2015, but essentially the same for every year. And what you see, instead of classifying tumors by stage, stage 1, stage 2, stage 3, stage 4, tumors are classified by whether they're localized, have metastasized regionally, or whether there's distant metastasis. And what you can see for almost every tumor type is that the stage of diagnosis of localized disease is less in populations of African descent, and the diagnosis of advanced disease is higher. So these numbers may not look particularly stark to you, but if you extrapolate that across the population, they are actually very significant numbers. There are many reasons for why there could be a lack of early detection. We'll go into that in a moment. But it's important, one of the reasons it's important, because again, as you probably know from your own work and your own other lectures, is that the stage at which a cancer is diagnosed has a very significant impact on its likelihood to be cured. And that's why there's such efforts to come up with screening programs for various diseases. And it's literally just the sooner, we've all been told it, but the sooner you diagnose a tumor, the more likely you are to cure it. A lot of research is done in the screening field from an interventional perspective, but also from a behavioral perspective, to try and understand what the barriers to screening are, and we'll talk a little bit about that later. But this is certainly an area where if we could increase the detection of earlier stage disease across the spectrum of cancer types, there could be possibilities for the reduction of disparities. So in terms of what we just talked about a little bit, so if access to screening is one of the factors that contributes to these differences in outcomes, what could the potential reasons be? So we know, for example, that in some regions there are barriers to screening, and this includes both minority populations but also rural populations. And it's a very practical issue. So in many cases, the screening centers are in urban areas, but if you live in a rural community, it's maybe not easier to get there. Or if there is a mobile clinic, it may not be a day where you're able to, you maybe have to be at work and things like that. So there's many practical issues associated with it. There's also evidence to suggest that the uptake of screening in some populations is lower, but it's never cut and dry. It's never simple. Like there's been studies that have been done here, for example, about mammography, the uptake of mammography, I should say. And even in a setting where you have equal access to care, in that situation, in this particular study, they found that there was similar use. But yet you have another example of colorectal screening where it's even in an equal access to care setting, there seems to be differential uptake. And it's also important to remember that even for cancer types where there is no screening modality, such as liver or esophageal cancer, we still see differences in mortality. So the point is, and I'm going to make this point several times throughout, is that all of these things are contributing factors, and they may contribute in different ways. There's no one solution, there's no one intervention. And even within the same cancer, it might also, the factors that contribute to it may also differ, depending on maybe the location that people live or their access to care. But it's just about being aware of the factors that can actually contribute, and that's the part that's important. This is also, so again, related to screening, this is just a table from one of the papers that we put out last year, the year before. So I mentioned a moment ago that screening for lung cancer was approved a couple of years ago. This was based on results from the National Lung Screening Trial. And what that study found is that patients with, sorry, I shouldn't say patients, but individuals who are high risk, these are people who smoked up to 30 or more pack years of cigarettes throughout their lifetime and were current or former smokers. If you screen those individuals, it was shown that you could prevent the mortality of lung cancer by about 20%. And this has now been replicated in Europe as well. Yes. Excellent question. So if you went into the physician and he said, do you smoke? And if you said yes, what he'd say to you is, he'd say, okay, how many cigarettes a day do you smoke? And you might say 10. And then he'd ask you, okay, and how long have you been smoking 10 cigarettes a day? And you might say, for 10 years. So 10 cigarettes is normally about half of a pack. So you basically multiply the packs by the number of years that you say you've been smoking. So that's essentially, it's a crude way of measuring smoking, But in general, for these types of studies, we kind of have to come up with some way. And obviously, per cigarette, not everybody might smoke the same amount. So it is crude as well in that stage, but that's a good question. That's what it is. So 30 pack year is given that definition. It is a lot, right? So we're talking about high heavy smokers here. So CMS have now approved screening for lung cancer in the United States, which is, a great thing. But and this isn't just restricted to lung, but if you look at the specific criteria for screening for lung cancer, it's based on the age of diagnosis. So you have to be within a certain age bracket, in this case 55 to 77. You have to have a certain pack year history, and you have to have either be a quit for a certain number of years. We'll get to a little bit later, but I told you earlier that African Americans are diagnosed earlier than European Americans. And also, as you'll see later, the smoking profile for African Americans and European Americans is very different. And so because of this, simply because of the profile of lung cancer associated in this population, the likelihood that they'll be included in screening criteria is less. And this has been shown now by a couple of studies. So it then begins to raise the question, well, first of all, should we come up with guidelines that are population specific based on the demographics that we know? And B, if we don't do that, is there the potential that disparities could actually get exacerbated? Because if you're less likely to include the highest risk population, then the extrapolation is that disparities would actually get worse. So this study here that we did, and some others by other colleagues in DCG and across the country, are all pointing towards the same thing. So there's an ongoing discussion about it. It's the same for breast, it's the same for colorectal. I don't think it has any specific population-specific guidelines have come in yet, but the data is suggesting that it's definitely worth a conversation to consider. One of the other differences for outcomes in terms of, or the higher mortality associated with cancer in populations of African descent, is also related to actual access to care, so for healthcare. And some of the strongest evidence, there's several papers, but this paper in particular also highlights that access to care measured by whether or not you have insurance is a good measure that suggests that access to care does actually impact your outcomes. So this is an example from, so the green line shows private health insurance, and then uninsured and Medicaid are shown in the other two lines here. And it shows for almost every cancer type that access to care has a significant impact on your cancer mortality. This obviously isn't, earth-shattering news for this audience, but it is important to remember. And to bring the point home a little bit more, this is work from Walter Reed, which is just across the street here at NIH. And this is looking at lung cancer specifically, and it's broken down by the 4 main histological subtypes of cancer. So this study was based on patients who were seen at Walter Reed, so it's an equal access to care setting. And as I mentioned a moment ago, lung cancer is one of those cancers where there is a disparity in terms of outcome. But if you look at the population within, and break it down by subtype, within an equal access to care setting, the disparity in terms of survival goes away. So what does that tell you? That tells you that access to care is extremely important in terms of reducing and eliminating cancer health disparities, especially for certain cancer types. Most of the disparities that I've mentioned to you are about African American and populations of African descent having the most adverse outcome. But I also just want to give you this particular vignette in the case of multiple myeloma, which shows that it is true that African Americans are more likely to have a higher incidence of multiple myeloma, but their survival, at least with current standard of care, they actually have a better outcome. So it's just, I don't want to paint a picture that it's always in that direction, but just this for multiple myeloma, this is one example. I talked a little bit about access to care a moment ago and how important it is. This is just a graph of the United States, and it shows the number of oncologists per 100,000 residents as you go across the country. And you can see there's massive heterogeneity in terms of just access to an actual oncologist once you've had a diagnosis. The bluer colors indicate greater access, so that would be these states, or these counties, I should say. This is a county map of the United States. And then these colors here in yellow is 0. So all the people who live in these areas have essentially very limited access to an oncologist. So this also shows you even more so, or a degree, how significant the access to care problem and how heterogeneous the problem is across the US. I know that here in the DC region, we're very fortunate. We have access to many, many centers of excellence, but it's important to remember that as you move out across the US, that certainly is not the case. I also want to make the point that, I've talked about settings where we do studies in an equal access to care setting and how disparities in outcomes go away. And that's true in a lot of cases. But I also don't want to make the statement that access to care always means access to quality healthcare, because it doesn't. This is an example of study for colorectal cancer from a paper in JNCI 2013. And it's showing racial differences within the same center. So all these people are showing up for care. But there are racial differences in the uptake and of surgery, chemotherapy, radiotherapy, and also in consultations, so who you're likely to see. So even in regular medical settings, studies suggest that racial disparities in specialist consultation exist, as well as subsequent treatment with various multimodalities. And this is for a metastatic colorectal cancer. Another thing, a lot of treatment these days also includes molecular testing. So in lung cancer, we do a lot of testing for EGFR mutations, for ALK fusions, things like that. And again, in a setting like we are here in DC, that's probably second nature. It's probably gone off for testing before you've left the hospital. But think about how there is a barrier to that sort of testing in a rural population, and not just the testing itself, but the interrogation and the communication of those results back to patients. And that is certainly a barrier that contributes and has potential even further in the future to contribute to disparities. This is data from a paper not too long ago in JCO, which again, I like the figure, I'll go through it in a moment, but it sort of shows again that there are various factors that contribute to disparities in mortality. Just to make the point again, it's not just one thing. So what they did in this study, A on the left is breast cancer and B on the right is prostate cancer. And they looked at various different factors that could potentially contribute to differences in outcome. So African Americans are shown here in blue, and European Americans are shown here in the gray line, so white populations. And they basically did rounds and rounds of statistical analyses and said, okay, try to ask the question, what are the main factors that would eliminate the disparities? And if by doing that, then try and come up with, okay, if we had to have one intervention, what would give us our best return for our investment? So at the beginning here, I'll take the example of breast cancer first. So this is showing that compared with European Americans or white populations, African Americans are over 2 times as likely to die from breast cancer than white populations. And what they find is that if you adjust for stage, and we talked about this earlier, the stage at which the disease is diagnosed is later in African American populations. So what this line is, that means that all else being equal, if all the tumors were diagnosed at the same stage, well, okay, you could eliminate this amount of the disparity. So it would go down to about 1.7. And then if you included, or if you considered surgery, so now everybody who has the same stage tumor has surgery, you can eliminate a little bit more. But you can see that there's many, many factors that you have to consider before you even get close. This is about 1.1 to eliminating the disparity. And so these trends differ across different cancer types, obviously. But the point is to make that the factors that contribute to disparities in outcome are multifactorial, and therefore require various different interventions to actually mitigate them. And this is just a quote from the paper, which says that yes, stage of diagnosis does have the largest effect on racial and ethnic disparities. But if we did have early detection and everybody was diagnosed at an earlier stage, it wouldn't entirely eliminate them. And that's what I was explaining here. And that the influences of neighborhood, socioeconomic status, marital status also suggest that social determinants and social support mechanisms, including access to care, are important contributing factors. It's actually quite a nice paper. They look at other cancer types and not just breast and prostate, and the reference is there at the bottom if anybody wants to read it. I'd mentioned about access to care, and just to go a little bit deeper, it's also, some of it also relates to the uptake of care. So in this case, this is work by Chris Lantham et al. He's done many studies on this. This is just one of them. But even amongst those with Medicare, so this example is shown here as patients with Medicare, they found that African Americans were less likely to receive treatment. And this was both surgery and also chemotherapy. So about 34% of African American men received surgery compared with 61% of white men. And that's actually quite a significant difference. There's also studies from a JCO paper a couple of years ago showing that African American renal cancer cell patients are also less likely to receive surgical treatment and compared with European Americans. So these differences in, once you actually are at the point of care in terms of the uptake of care also exist. And this is another example here for African Americans in terms of colon cancer, again showing a similar thing. So one of the questions is, well, why would this be the case? And again, you know, I probably sound like a broken record at this stage, but it is multifactorial. This is data from a lung cancer study. But what I found using the the Health Information National Trends Survey, and what they found is that in terms of lung cancer, African Americans are more likely to hold beliefs that about lung cancer that would probably interfere with how they would approach prevention and treatment of the disease. They found that African Americans were 3 times less likely to get a lung cancer checkup, and 2 times more likely to expect symptoms before a diagnosis. And of course, for lung cancer and many cancers, we know this is not actually the case. And they were also 2 times less likely to agree that getting checked for lung cancer could help find the disease early. So the potential factors that feed into this are, again, multifactorial. They can include personal beliefs, it can include fear, culture. What's very important is the doctor and patient relationship, patient bias, provider bias, communication between the patient and the doctor, but also importantly, comorbid conditions. So we didn't mention this when I showed the graph earlier from Chris Lentham and colleagues, but you know, surgery is a serious intervention, so not everybody's a good candidate for surgery. And a lot of comorbid conditions that could interfere with the successful surgery or the successful outcome from a surgery are also factors that contribute to those differences in uptake across populations. But for some cancers, even as we talked a little bit about earlier, even in equal access to care setting, even in settings where everything looks equal, disparities still exist. And this is an example from breast cancer. And breast cancer and prostate cancer are probably 2 of the major cancers that fall into this example. So this is an old graph, that's why it looks all kind of faded, but it basically makes the point, is one of the first studies to show it, that even in this equal access to care setting, European Americans have a better outcome compared to African Americans. And if you look in a clinical trial setting where everybody's essentially getting excellent, well, what we assume is excellent care, and you look at outcomes there, this paper from JNCI from a couple of years ago shows, so the line here that's dotted, any number or any line that doesn't cross it is statistically significant. So I've highlighted those in red. But it shows for pre- and postmenopausal breast cancer, for advanced non-Hodgkin's lymphoma, for advanced ovarian cancer, and for prostate cancer, that even in a high-quality access to care setting, disparities still exist. And so then you have to ask the question, well, are there differences in response to therapies those patients are receiving? And does that therefore indicate that there could be differences in biology between these tumors? So we're going to spend the next couple of minutes determining what role, if any, biology plays in cancer health disparities. And it's important to view this part of the talk in the context of all the other factors that we've talked about in the first 20 minutes or so. So going back to prostate cancer just for a moment, we've known for a while that prostate cancer tends to present at a more aggressive way than it does in European Americans. And in prostate cancer, the way that this aggressiveness is scored is something called the Gleason score, and you might have come across this already. So it has a range, and this is how it starts to be scored here on the left. But what you can see here on the right is the higher the score, the more aggressive the disease is, essentially. And you can see that it's shown that African Americans are more likely to present with these aggressive scores. So it's shown up here. So less likely to be less aggressive, more likely to be more aggressive. And we've known this for a while. What's interesting is there's been quite a few papers now that have shown that some of this aggressive behavior can be linked to germline genetics or genetic susceptibility. So you probably have heard of GWAS studies up to now, so genome-wide association studies. And these are studies that basically profile not all the SNPs in our body, but essentially try and get a good map of what our germline genetics are. And then ask the questions, are there any regions, any hotspots that are associated with risk of developing cancer throughout your life course? And one of them that frequently comes up is on AQ24. So you'll probably all have heard of the MYC gene, c-MYC, and this is part of the locus where c-MYC is. And it's been known that it's been associated with prostate cancer for a while and many other cancer types as well. But a group led by Matthew Friedman and others found that if you look at the specific locus and some of the regions on it that are associated with prostate cancer, there's an excess of African ancestry there in terms of genetics. And they've been able to quantify that 50% of the racial differences in prevalence map back to this region. And it's been shown now quite a few times. And there's another region on chromosome 17 which seems to again have an excess of African ancestry, or alleles that are only present in populations of African descent. And that the region on chromosome 17 seems to contribute about 10% of risk. So again, it's not 100%, but there's certainly good evidence that this particular region has an important contribution. And work by Isaac Powell at Wayne State has also shown that this same region, which is more common in men of African descent, seems to contribute to some of that aggressiveness that I talked about 2 or 3 slides ago, and also faster disease progression. So the SNP that they're talking about in the study, so a non-carrier, one carrier of 1 risk allele or 2 risk alleles, you can see that it's associated with a higher Gleason score and a higher likelihood, significantly higher likelihood of lymph node metastasis. So that's just one example of how there seems to be a link between genetics with the aggressive presentation in one population over another, and especially in the area of something that has a direct relationship with outcome and mortality. This is just a graph to show, this is just work from our lab where, most in our studies, when we study European Americans and African Americans, it's about self-reported race. That's how we normally study it. But of course, with genomics these days, you can essentially quantify ancestry. And every population has a degree of admixture. And what these types of assays do, it gives you a percentage of ancestry. So this is from our case control study, and these are all the African Americans enrolled in our study. They're self-reported African American, and what we had done was just conduct what's called an Ames analysis, or an ancestry informative marker analysis, to quantify the percentage of West African, Native American, and European ancestry in the population. And as you can see, obviously, the majority of the populations, they have a majority of West African ancestry, which is, of course, expected. But you can see across, even with a population, this is within the Baltimore region of Maryland, even within that small population, you can see quite varying distributions of European ancestry. And for the example I showed you a moment ago, excuse me, in terms of prostate cancer, it seems to be, at least in some cancer types, this West African ancestry can be associated with more aggressive disease, at least it was in prostate cancer, and could actually contribute to our understanding of where these disparities come from. It also seems to be important in terms of leukemia, in terms of Native American ancestry. So this is quite work from a seminal paper a couple of years ago, and it found that there was first of all, that an increased proportion of Native American ancestry was associated with an increased likelihood of childhood acute lymphocytic leukemia. Of course, that has screening implications, and very important screening implications, but it was also related to treatment, because what they found, and this has been an observation for a while, is that, and what it is translated to, is that children with more than 10% Native American ancestry need an additional round of chemotherapy to respond to that treatment. It was quite obviously it's a very interesting study, but you can also see it's one where it has immediate translation, both in terms of screening, but also in terms of treatment and the likelihood of that treatment having a success. And it's an example of how, in some cases, that looking at ancestry informative genetic markers gives a greater granularity when you're trying to study the intersection between genetics and genomic studies. So that section really talked about germline genetics, but then I also want to talk a little bit about somatic genetics. So these are mutations that only occur within a couple of cells within the body. In most cases, and we see this in our own studies as well, when you profile at a somatic genetic level a tumor from African Americans and a tumor from European Americans, or even from a Hispanic population, the broad spectrum of mutations are the same. So you'll see P53 mutated and KRAS, so those sort of things are the same. But normally what we see, and this is what this group have seen as well, is that there are pockets of mutations where you do see differences. And this is an example from colorectal cancer. It was a paper published a couple of years ago. And they see an increase in mutations in African Americans in Ephrin A6 and the FLCN gene. And these mutations are rarely ever seen in populations of European descent. So it shows that they're, at the broad scale, yes, a lot of what we see is the same, but certainly at specific focal areas, there are differences. Again, similar, just going back to prostate cancer again for a moment, one of the most frequent genetic alterations in prostate cancer is with the ERG gene. And studies have been done now in populations of European descent, Asian descent, African descent. And what's really interesting is that the frequency of that ERG fusion gene, and indeed of PTEN mutations, is different. So there's a very high frequency of this oncogenic temperous ERG gene fusion in populations of European descent. It's about 50%. And this is a very oncogenic transformation. And it's found in many, many different types of prostate cancer. But if you look at populations of African descent, it's only about 25 to 30%. And it's quite uncommon in populations of Asian descent. In addition, in terms of P10 loss is very common in populations of European descent, but it's rarely ever found in populations of African descent. And we see this in lung cancer too. I mean, a lot of this talk is about disparities within the United States. But if we even look at lung cancer, one of the most studied mutations is in EGFR. And we now have targeted therapies for those mutations. But in populations of Asian descent, those mutations are very high. Whereas in populations of European descent, it's mainly about somewhere between 10 and 25%. And it's related to, in that case, it's related to the exposure, because these mutations are more likely to be found amongst never smokers. So again, that's just to step out of the United States for a moment. Most of the disparities that we're talking about are within the US, but it's also important to remember as you go to other countries as well, we do see disparities and differences in the types of genetic mutations that are found. And in many cases, we're able to track that back to different exposures. This is a figure from a paper that was just published last week. And the authors took data from TCGA. So they looked at the CNV, so the copy number data, and they also looked at somatic mutations from pretty much all the, I think it was like 13 or 14 different cancer types. So they took out all the data and grouped it by, well, there were self-reported rates, but then they also did their own genetic ancestry analysis, like I had mentioned a moment ago. And what they found was that for cancers of the breast, the head and neck, and for endometrial, that African Americans had higher levels of chromosomal instability than European Americans. They did not find that in any way related to outcome, but it certainly seemed to be different in terms of just the genetic architecture of the actual tumors. And they also found a higher frequency of genetic alterations in the PIK3 kinase, or the PI3K kinase pathway, which is, again, a very frequently perturbed pathway in cancer. And the frequency of that pathway is actually lower. That's what they found in European Americans. So what they're showing here is, this is different types of kidney cancer. And on the right in the red dots, you can see that it basically shows there's a more likely to have genomic instability in these breast cancer, or in these tumors, compared with European Americans. That's how the graphs are shown. So this is a very recent paper. There's lots more detail in it, but the two take-home messages were that at a global level, for these three particular types of cancer, there were higher levels of chromosomal instability. The implications of that, of course, need to be fully studied and understood. So in continuing the conversation a little bit about molecular subtypes, I mentioned a moment ago, or a couple of slides ago, that the molecular subtypes of tumors also tends to be different by populations. And one of the very first examples of this relates back to, essentially, to breast cancer. The 5 or so main molecular subtypes, many of them are broadly based around the estrogen receptor, the progesterone receptor, and HER2, essentially, and HER2 amplification. And what's been found, this is just a snapshot of a paper from 1994 from the Carolina Breast Study, which was one of the first to show it, but it's since been borne out by many studies. And what it shows is that populations of African descent are more likely to be triple negative, which means they don't have ER, they don't have PR, and they don't have HER2. And the reason that's of significant public health importance is because, number one, it's one of the most aggressive subtypes of breast cancer there is, so it's going to have a significant disparity in terms of outcome. But secondly, most of the ways that we treat breast cancer target the estrogen receptor or the progesterone receptor or HER2. So the therapy options are quite limited. So I'm not aware of much literature that really has explained why it is the case that populations of African descent are more likely to have triple negative breast tumors. But it's been seen in many cases now, and it's probably one of the best examples of molecular differences by race and histology in the United States. But it is important to, that said, again, it is important to say that even within subtypes, so disparities can persist. And this probably comes back to the issues of, access to care that we talked about earlier. So when I say that triple negative is more likely to occur in populations of African descent, that doesn't mean there aren't disparities related to the other types. There is, and so it's important not to ignore those. And work from our lab looking at lung cancer last year showed again where we see many, looking at the transcriptome now, so moving on from somatic and germline genetics. When you look at the transcriptome, again, we see many similarities in gene expression when you just compare two populations of European descent and African descent. But when you look at the gene expression networks that you only find in each population, what we found was that for European Americans, there was an overrepresentation of pathways related to cell proliferation. And for African Americans, so red meaning higher, there was an overrepresentation of pathways related to stem cell invasion. And we've also, you can use fancy bioinformatics tools these days to try and infer what the immune microenvironment is within a tumor in terms of what cells are likely to have infiltrated. And the transcriptomic evidence suggested to us that there were differences in macrophages and some other cell types actually. And this is work that we're currently following up on, looking specifically at those cell types within the tumors. Also wanted to mention some work again at the transcriptomic level by a colleague of mine, Stefan Ams, who's in the same branch that I'm in. And a couple of years ago, again, using a similar sort of approach, using the transcriptome to profile tumors from African American men and European American men, what he found was that there was this predominance of what was called an interferon-related signature in prostate tumors from African American men. And this was an observation from 10 years ago. It was a paper by Tiffany Wallace and Stefan Ams. But what's really interesting is that in the period in between then and now, essentially, a colleague of ours at DCEG discovered a SNP that led to expression of this interferon-related gene, interferon lambda 4. And this specific allele, this delta G allele, is primarily, an emphasis really is only primarily found in populations of African descent. And what he's shown now in a recent paper is that not only do African American men more likely to carry this interferon-related allele, but if you do have this allele, you're more likely to have this interferon signature. So what he discovered before, about 10 years ago, showing that these African American tumors tended to have more of an interferon signaling signature, he's now gone back to discover that the reason for that is probably because they're more likely to carry this specific genetic polymorphism. So it's an interesting study that is at the moment coming full circle. Most of what we've talked about in terms of biology has been in terms of germline genetics or the transcriptome. But some of the things that we also study in our lab is the circulation. So biomarkers, the idea that, for any population, we try and study biomarkers that will help us in terms of early detection and predicting prognosis. But because we're aware that there are differences in the biology within tumors, we're also aware that the biology in the circulation of a European or a patient who's African American or European American could also be different. So again, it's important to say that some of the studies that we have done have looked at differences in inflammation-based proteins. And we primarily did this because there is this documented relationship between inflammation with lung cancer. And in terms of inflammation in the circulation for both populations, we see IL-6, IL-8, CRP, interferon gamma. So these things are common. But we also see some proteins only associated with diagnosis in African Americans that we don't see in European Americans. And two of the examples are here, IL-1 beta and IL-10. What's shown here are odds ratios, and these are quartiles of expression. So this would be low expression, this is then a little bit higher, and this is the highest expression. But you can see if an individual presents with high levels of IL-1 beta, they're 3 times more likely to get a lung cancer diagnosis, but in European Americans, there's just no such association. So again, what this tells us that in some cases, the biology is different. What we don't know and what we have been trying to investigate is what causes this, and we don't actually know. And reciprocally, there are some proteins that are associated with diagnosis in European Americans that we don't see in African Americans. The importance of this is especially in lung cancer, there's a really strong push at the moment to there's a need for biomarkers essentially to complement screening. And so what this says to me anyway, as a biologist, is that while there may be utility in some of these markers in terms of diagnosis and maybe even risk stratification, it would be foolish to think that every protein is going to be as effective in every population. And our data and data from others also supports that. I'm going to spend just a couple of minutes on geographical factors that relate to cancer health disparities, and then we'll finish up talking a little bit about tobacco. So I put up a graph earlier that was sort of like a county level map of the United States, and it showed how access to oncologists vary quite a degree across the country. And most of the incidence and mortality estimates that I've given you are it's all collapsed down as for the country as a whole. But it's important to note that if you look across the United States, for every cancer for any cancer, I should say, and you can do this just by going to the CDC website, you'll see significant heterogeneity in the incidence. This is shown for all cancers combined. But if you break it down by any cancer type, you will see significant differences. The states with some of the highest cancer incidences include Kentucky, Rhode Island, Delaware, New Jersey, and the lowest include New Mexico, Arizona, Wyoming, Alaska, and Virginia. There are many, many, many factors that contribute to this, but one of them is worth highlighting is obviously tobacco. And tobacco use is amongst the highest in Kentucky, as are actually some of the lung cancer rates, the highest in the country there. So yes, tobacco is important in terms of contributing to these differences by state, but so again, coming back to something mentioned earlier, what this graph shows is rural and urban disparities in cancer mortality. So over here on the left-hand side of each graph, you have the incidence rate, and then over here you have the death rate. And the increasing colors in terms of white to brown, what they show is increasing urban residents, essentially. So for lung cancer, you can see that people living in an urban area are less likely to have a lung cancer diagnosis, and they're also less likely to die from the disease. This is overall, but also late stage. For breast cancer, it's the opposite. So individuals living in a metropolitan area are more likely to be diagnosed. But this might actually also be because of screenings. They may be more likely to have access to screenings. They may be more likely to have an actual, to get an actual diagnosis. But what it shows is that where you live matters in terms of whether you get cancer, but also whether you die. And the NCI specifically has increasing efforts to try and address rural and urban health disparities. And this is a study, or this is a picture from a study that we did last year, the year before, in collaboration with the CDC, where, again, we knew there were disparities by lung cancer across the United States, but we wanted to see where the disparities, did it matter where you lived, essentially. And what we found for both adenocarcinoma and squamous cell carcinoma in men is that while the amount of lung cancer was higher in African Americans, regardless of where you lived, the degree of that disparity increased with a more rural location. Now, we don't know why that is, but it could be related to tobacco, but it could also be related to something else. There are many reasons for why where you live might impact your risk of cancer, but also the likelihood that you might die from it. Many of these include, obviously, social economic status, which we've shown definitely contributes to mortality risk. Access to preventative services, we've talked about that playing a great role, but also an unequal burden of pollution. Also, we touched on this a little bit earlier, but rural populations are also more likely to have increased cancer incidence and an unequal burden of pollution, and also to forego medical care and prescriptions, possibly in some cases due to cost. As I mentioned, the NCI is putting quite a bit of effort at the moment into various initiatives to try and specifically address and study cancer health disparities in rural and urban areas. And that's essentially, if you want to know more about it, it's essentially there. But there's quite a bit of a focus in DCCPS, which is one of the extramural parts of NCI. So I wanted to spend the last couple of minutes talking about tobacco, mainly because it's the major leading cause of lung cancer and also several other cancers. But also by race, there are significant disparities in tobacco across the United States. So in terms of, so what I've shown here in the top two slides, first of all, is just the incidence of cancer by both men and women in terms of order. And you can see that African American men and women have the highest incidence of lung cancer. And given that I just told you that tobacco is the major cause of lung cancer, you might expect to see a very similar linear graph. But of course, that's not what you see. So even though lung cancer incidence is the highest in African Americans, they don't have the highest prevalence of smoking. So what's shown here on the graph is high intensity smoking. So this would be smoking like 20 cigarettes or more a day. 19% of European Americans smoke about 20 cigarettes a day, whereas only 6% of African Americans do. So essentially, when it comes to tobacco and lung cancer, there's a bit of a paradox. Some of the things that we do know, we know that African Americans start smoking later, but yet they're diagnosed earlier. So we don't understand why that is. We know that in general, African Americans smoke fewer cigarettes per day. And this has been shown, this goes back to like the 1900s. This isn't a recent phenomenon. We talked a little bit earlier about temporal trends, but it's always been shown that African Americans were more likely to smoke fewer cigarettes than European Americans. But yet, they get more lung cancer. And we don't know why that is. It's also important to note that disparities are observed in never smokers. So what does that tell us? It tells us that there's some other factor that's important and worth considering. The other thing is one of the major differences in tobacco pattern use between European Americans and African Americans is the type of cigarette that's used. So about 70 to 80% of African Americans use mentholated cigarettes, and about 20 to 30% of European Americans use mentholated cigarettes. And several studies have looked at whether or not menthol cigarettes are somehow associated with a higher incidence of lung cancer, but it's not. And if you compare menthol to a non-menthol cigarette, the risk of lung cancer is certainly not higher and is probably less. So again, it kind of compounds the disparity a little bit more. The one thing that's definitely ingrained in the literature and in experience is that African Americans are less likely to quit smoking. There can be many reasons for this, and access to smoking cessation programs is certainly one of them. And so what that means is that the duration of smoking within the life course is longer for African Americans. And one of the studies that we're currently doing is to compare between these populations the duration of smoking and the intensity of smoking to see if we can identify any racial patterns or any racial differences in those populations. This is work from, well, about 12 years ago now, but it's quite a seminal paper in New England Journal of Medicine. And what it did was, using the multi-ethnic cohort study in Hawaii, tried essentially to break down, okay, let's just look at cigarettes per day and see if the disparities still persist. So it's broken down by gender, so men on the left and women on the right. And what you can see is that even if you just take out the people who smoke the same amount, so everybody in this group here smokes 10 cigarettes a day, but what you find is that African Americans here in the purple line still have the highest lung cancer risk than European Americans, which are shown here. And here you have Native Americans, and then Japanese Americans and Latinos are shown here at the bottom. So what this paper suggested is that, and this obviously increased, the difference still persists at higher amounts of smoking, but it's less, as you can see here. But you see a similar trend in women. So this was a bit, so it was interesting, but it suggested that perhaps for some reasons that we don't understand, there was a higher susceptibility to tobacco in African Americans. And that could be the case. We don't actually know that. GWAS studies have been done, but they haven't highlighted any major genetic difference like we saw for the prostate cancer. Yes? So this study, as far as I'm aware, it didn't. I'd have to go back to the footnote on the table, but I don't remember seeing alcohol use in it. There isn't very strong, I can go back to the reason for your question in a moment. There isn't very strong evidence for a relationship between alcohol use and lung cancer, as there would be for maybe breast cancer and probably like a reciprocal relationship. I don't think it has adjusted for it. I can go back to the table and check because it is a good question. But so what this sort of suggested was that, yeah, there was a greater susceptibility to tobacco in one population, maybe that compared with others. But just to go back to the point that I made to you earlier as well, you may say that you smoke 10 cigarettes a day, but if somebody only smoked half that cigarette, then they're obviously going to take in less carcinogens than somebody who smoked all of it. And work from several groups, but including Sharon Murphy and some authors also from the next study, name is passing me for a moment. But essentially what they did was they measured the amount of total nicotine within the urine of people who smoked. And even when they took into account enzymes that could change how you metabolize nicotine and all those sort of things, what they found was that per cigarette smoked, in a sort of control, well, not control study, but reported cigarette smoked, African Americans had more intake of nicotine. And what that suggests is that for every cigarette smoked, African Americans are smoking more of the cigarette. And that may actually explain why there are more disparities. We don't know that for sure, but that at least is what some of the data are suggesting, which is an interesting observation. There are, I'm a little short in time, so I essentially repeat a lot of things I just said on the earlier slides. But suffice to say that any interventions that increase smoking cessation across all populations, obviously, but especially minority populations, are very much continue to be needed. And the lung cancer screening that I mentioned earlier, smoking cessation counseling is a required aspect of that screening in order for the physician to be reimbursed. And that's obviously, hopefully, something that is positive, but hopefully will continue. So In recent years, you might have seen several joint statements from leading bodies within the United States, including the AACR, ASCO, the American Cancer Society, and even NCI, who recently put out a joint statement where they sort of tried to take an assessment of where we were in terms of what we knew about cancer disparities, the factors that contributed to it from a cross-sectional approach, and also trying to think about, how could we, what measures could we take to try and reduce disparities. And so these are some research priorities that they've come up with. Most of what I'd mentioned, I hope, during the seminar today shows that the factors that contribute to cancer health disparities, both in terms of income or incidence, but also in terms of outcome, are multifactorial. The part that we mainly study in our lab are related to genetics and biology, but there's many groups across NCI, but also across the US, that are focusing on all these other aspects, including access to care, exposures, and also, very importantly as well, social determinants. This is a slide I often go back to at the end of my talks. Again, I don't, I work in a tiny little aspect of this, but I'm always reminded when I look at our studies, both in terms of what we're trying to understand, but also how we try and implement it, that the approach to trying to both understand disparities, but also to design interventions to reduce them, is definitely multifactorial. That's one of the reasons why I think I'm lucky to do my research here at the NCI, because we get to work with colleagues who work at the interface of a lot of these different areas, and they inform our thinking of both the way we design our studies, but also the way that we think about how we could potentially translate what we find afterwards. So with that, I'll stop. I'll take any additional questions. I think you have my contact details if anybody has any follow-up questions. And if I don't know the answers, I'll refer you to somebody who might. So thanks for your attention. Mm-hmm.
And you had that private insurance versus Medicaid versus uninsured.
Mm-hmm.
And Medicaid looked like it was either equivalent or,
mm-hmm.
or in some cases a little bit lower on the trend line than why would that be? Or what was the difference in care of Medicaid versus being uninsured?
So I don't know. Okay. Yeah, and I mean, when a lot of these studies are done, they generally just it's aggregated data. So I know I saw that too when I read the paper first. So I don't know what the differences are. So I'm afraid I'm not able to tell you. Yes.
On the slide, this is number 12. There are a couple exceptions to the rule where shows localized other cancers and regional black patients' survival higher slightly, if I understand that correctly. I'm wondering what might be,
Sure. Can you flip it around so I can see the slide that you're referring to? Oh yeah, that one. Okay. So straight off the bat, I don't know a lot about kidney cancer, so I'm not going to pretend that I do know. When we see differences in stage of presentation, oftentimes it's really two things. Number one is their screening modality, and then if there is, are there differences in access to care for why one population might source it out versus another, or are there population differences in how early grade lesions might actually progress. The other difference maybe in whether or not disease is actually symptomatic or not, and at an early stage versus another disease. I mentioned, I don't know if you were here at the time when I mentioned the multiple myeloma, excuse me, the multiple myeloma slide. Most of the disparities, unfortunately, in the United States disproportionately affect populations of African descent. But there are a couple of examples where the outcomes are different. Obviously, it'd be better if there was no disparities anywhere, but multiple myeloma was one example where survival tended to be better in African Americans compared with European Americans. Why we don't know. But you mentioned kidney was one example, and what was the other example? Yeah, well, melanoma, I guess, I'm extremely pale. I come from Ireland, so, it's probably easier to see something on my skin that looks suspicious or aggressive compared with, somebody who comes from Africa, where it's probably harder to see that. So I'm guessing. I don't know for sure. I'm just saying that's probably one reason why it's harder to detect it, or easier.
be that more of the African Americans live in the South.
Yes. Yeah, exactly. But of course, the goal is that those graphs that you're looking at are flat. That's the goal.
Okay, Brid,
Okay,
thank
agree.
you.
Great. Thanks very much.
Hey, for those who are interested in case reports, we have our next speaker, Dr. Olaku. He's with the Division of Cancer Treatment and Diagnosis, and he brings the case reports to you.
Thank you. Thank you, Dr. Moody. Good evening, everybody. Thank you for staying back to listen to case reports. This is not going to be as complex as health disparities. It's going to be very straightforward, and we'll be out of here before 6 o'clock. So the goal that I have this afternoon is to describe the history of case reports and say a few things about the potential roles of case reports, describe a few case reports to give you an idea of different types. So I'm not going to go into the detail of each one, but I'll give you enough summary to appreciate the case reports and what to outline the pertinent information for a good case report. So this is one definition of case report. A case report is a formal summary of a unique patient and his or her illness, including the presenting signs and symptoms, diagnostic studies, treatment course, and outcome. Looking at the history of case report, some of the case reports, it's thought that the oldest preserved medical literature containing clinical cases is a text from an Egyptian antiquity papyrus around 1600 BC. Some people believe that this may have been rewritten from earlier centuries. Among these were 48 cases discussing injuries or disorders of the head and neck, head and upper torso. In the history of case reports, you find that there are some names that are associated with these case reports, and these are prominent people who played a role at that time. We have what we call the Hippocratic case histories, and this the unique thing about Hippocratic case reports is that they are retrospective accounts that focus on describing the findings and observation of the cause of the disease. In those case reports, they highlight the mental and physical findings. However, the patient's version of his or her complaints are for the most part absent. Then we go to what we call the Galenic case report in the 2nd century. The new thing in Galenic case reports is that they have what is described as a conversational tone in the reports. And Galen described his working day, his doubts, his tentative diagnosis, and his interactions with other physicians as the disease unfolds in his case reports. It appears that in the Middle Ages, that clinical medicine in the Western world was dormant. However, at the same time, there was a lot of medical literature from the Islamic world. The case reports were similar to what we have the Hippocrates and the Galen case reports. Around the 17th, 18th centuries, we began to see emphasis on the patient's subjective experiences being included in the case reports. The physicians were a bit dramatic in the way they wrote the case reports, and the whole idea was to heighten the narrative tension and degrees of their involvement in suffering patients or subjects. This is an example of the kind of titles they have. This was a case report in Philosophical Transactions in 1739, and the title is that a girl 3 years old who remained a quarter of an hour underwater without drowning. In the 19th century, the case reports had less information about the patient's subjective accounts. So they started to introduce medical terminology into the case reports. And the case reports were organized into sections. For example, demographic details of the patient and outline of the clinical course of events. Looking at cancer patients, the history is similar to case reports for other diseases. And Milojenicek, in his book, Clinical Case Reporting in Evidence-Based Medicine, describes case reports as the first line of evidence where everything begins. Similarly, some of the earliest case reports were seen in the ancient Egyptian medicine around 1600 BC, and these were the first recorded incurable tumors of the breast. Now we go to what are the potential roles of case reports and case series. Case reports can be useful in the recognition and description of new disease. For example, West Nile encephalitis was described in 1999 in New York City. It was new to the United States at the time. Now, almost every summer, there may be some few cases. But at the time, it was new to the United States. Another area that case reports, potential role that case reports can have is in the detection of drug side effects. This could be adverse or beneficial. Most of the FDA drug retractions are usually due to case reports that are sent to them, to the FDA, and then those drugs are withdrawn. But there are also examples of beneficial side effects. For example, sildenafil was a drug that was designed to treat cardiovascular disorders. But in the process, they found out that it was beneficial to treat erectile dysfunction, which is what is being used for today. Case reports can provide an opportunity to study the mechanism of a disease. For example, in maternally inherited diabetes associated with deafness, again, because it was the case reports that were available led to the discovery of the mechanism of the disease. It can be useful in medical education and audits. For example, we have case reports in the New England Journal of Medicine where they would detail a patient's case and everything that they did and all the discussions they had by the different specialties that were involved in the management of the patient. It can also be important in the recognition of a rare manifestation of a disease, as we'll see from some of the cases that we'll go through. And also, case reports can impact on health policy. For example, in Florida with Zika virus, the state had to make some policies when it appears that there were cases of Zika virus probably might be in the United States. So case reports is what leads to some of these things. Case reports describing new disease and diagnosis. Historically, case reports was communications between physicians, which became the origin of journals. And Hippocrates and Rufus of Ephesus described melanoma cases. And in 1832, Thomas Hodgkin reported 6 cases, 2 of which is what is now known as Hodgkin's lymphoma. Similarly, in 1957, Dennis Bucket described a tumor that presented in the angle of the jaw of African children, again, what we know today as Burkitt's lymphoma. As recently as 1990, Fassett and colleagues described 2 patients with a new type of lymphoma called hepatosplenic T-cell lymphoma. So we look at some case reports. This is a young female athlete with acute low back pain caused by stage 4 breast cancer. This is a 27-year-old lady that presented to the office of a chiropractor with a complaint of lower back pain after warming up and participating in kickball. She reported feeling some discomfort while jogging and subsequently having pain after striking the ball with her right foot. The pain was located at the lumbar 2-3 level with mild radiation into the right paravertebral region. Pain was constant, sharp, stabbing, and rated as 8 to 10 on a numeric scale. There was no radiation or paresthesia into the extremities. She had a past history of an unplicated low back pain that had been managed conservatively, which was thought at the time to be attributed to lumbar scoliosis. On examination, she had decreased flexion and extension, and the active range of motion with pain in the upper lumbar area. She was tender in that area. The reflexes of the patella and the Achilles tendon was 2 out of 4 on both sides. The Babinski and lower extremity clonus were absent on both sides. The muscle tone was fine, but however, there was increased paraspinal muscle tone was noted at the level of the complaint. She had a positive family history of breast cancer, and she had routine mammograms because she had a cyst in her right breast that they had been monitoring over a period of time. So because of the pain at the back, it was diagnosed as a sprain or strain with a differential diagnosis of spondylolysis. A radiograph was obtained to rule out spondylolysis, did not reveal any fracture or dislocation. And one of the interesting about this case that I want to point out is that at the time, the radiologist did not think anything was abnormal. But after she was diagnosed as breast cancer down the line, they now went back to look at the X-ray. They find out that in retrospect, she had subtle lucencies that were visible on the vertebral body and the left pedicle that could have alarmed them that something may be wrong at the time. And you can see the arrows there, you know, you say it takes the eye of faith to see, but there's some lucencies that may make them feel that that's not normal, again, on this side. So she was had to have mobilizations of the lumbar spine and hips, conservative treatment for 2 weeks. She even went to see her employer's physician who just prescribed anti-inflammatory drugs and physical therapy. The goal of that was to strengthen the core musculature and increase the range of motion. However, 2 weeks after all of this, there wasn't any relief, so she returned back to her chiropractor, and they now requested for an MRI scan that revealed a 2.2 centimeters expansible lesion in the left L2 vertebral body with associated overlying vertebral superior end plate concavity focally. At the time, they thought, differential diagnosis was that she had a hemangioma, possible pathologic fracture, giant cell tumor, or metastatic disease of unknown origin was made. Now, if we look at this, you can see the lesion on MRI. It's a bit clearer here. You can see it here. And this is destruction of the superior end plate. Again, here, you can see infiltration of the pedicle there. So it just shows that sometimes case reports is what will help to broaden one's knowledge, because the way this lady presented at the beginning, nobody will have thought that she will have had breast cancer. She's a young lady at 27, very active. So she was referred to the oncologist because of this, and she was diagnosed as stage 4 breast cancer at the time. She had a mammogram and ultrasound-guided biopsy that revealed the cancerous tumor in the right breast. Interestingly, the cyst that she had that they've been monitoring was normal. So this is an additional thing with the cyst she had initially. They found 2 more metastatic lesions in the C6, C7 spinal levels via the bone scan and MRI. Tumor was HR positive and HER2 negative. Like I said earlier on, the original cyst was benign. She was treated with those drugs, letrozole, Ziva, Ibrance, and Faslodex. She had a right lumpectomy and axillary lymph node were removed. This was in 2016. Spinal lesions diminished in size. However, she had a new metastatic lesion that was confirmed in the liver. As at the time this case report was written last year, she was on a trial on Xeloda, and she was currently active, living her life. This is a metastatic renal medullary carcinoma treated with immune checkpoint inhibitors. This is July 2016, 40-year-old woman, experienced several episodes of blood in the urine. CT scan revealed a solid mass within the minor and intermediate renal calyx of the left kidney, measuring 30 millimeters. She also had multiple lumbar aortic lymph nodes, largest diameter 16 millimeters, and some sub-centimetric pulmonary nodules. Surgery was done. They removed the left kidney, left lymph node dissection in August of 2016. Pathology, she was graded as PT3A-N2 renal medullary carcinoma a grade 3, according to 2013 International Society of Urological Pathology grading system, with 4 of the 9 metastatic lumbar nodes positive. Immunohistochemical analysis showed that it was negative for TTF1, P63, GATA3, and positive for PAX8, RACE-MACE, CK7, and CD10. She had a follow-up imaging in December 2016. There was an increase in size of the pulmonary nodules, and there were new metastases in the mediastinal and para-aortic lymph nodes. She had palliative chemotherapy with cisplatin and gemcitabine, was given in January 2017. Follow-up CTs after third cycle revealed a reduction of pulmonary and lymph node lesions, but new bone metastasis to the right parietal bone, sternum, D7 and L5 vertebra were detected and confirmed by scan. As a result of that, they started palliative radiotherapy and zoledronic acid. At the end of the 6th cycle in May 2017, CT scan revealed an increase in the disease burden of both pulmonary and nodal metastasis. So they started a second line of treatment, nivolumab, in June 2017. After 6 cycles in September 2017, the CT and bone scans revealed partial response with reduction both in terms of number and size of the known bilateral nodules, and a volumetric reduction on the lymph nodes. CT assessment, April this year, confirmed response in all disease sites, and she's still on, as at May 2018, she was on nivolumab treatment. So you can see the before and the after. These are the lungs. It's less here. This is the parathoracic, the lymph nodes. Again, you can see the size is not as much on this side. This is a pediatric patient, 2 years old, conceived by in vitro fertilization. Birth weight was within normal range. Prior to presenting, she was well. 3-week history of lethargy, irritability, vomiting, and abdominal distension. Examination revealed an enlarged liver confirmed by CT scan, hepatic mass, bilateral lung nodules. Serum alpha-fetoprotein level was 1.4 million nanograms. That's very, very high. I mean, very, 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 how many varies? High, because the normal range is 10 and, and below, so that's very high. Liver biopsy confirmed hepatocellular cancer. She received 7 cycles of cisplatin and doxorubicin and sorafenib. They had to reduce the sorafenib by 25% because of febrile neutropenia with prolonged myelosuppression. After 6 cycles, alpha-fetoprotein values were normal. Hepatic mass had shrunk, while some of the pulmonary nodules remained. You can see the mass here in the liver and some of the nodules in the lungs. Not as big on this one, and some of the nodules have cleared in the lungs on treatment. So they had a resection after treatment, was staged as pre-tech stage 3 and post-tech stage 2. Macroscopically, the tumor was completely resected. However, the resection margins were infiltrated by the tumor, and histology showed mixed tumor with both hepatocellular carcinoma and hepatoblastoma elements. So this is the hepatocellular segment, and this is the one with the fetal parts, cells in the biopsy. So she had maintenance therapy with sorafenib for 12 months. After that, there was complete resolution of the pulmonary nodules. Patient is alive, disease-free, with normal cardiac, renal, and auditory function 41 months after presentation. This is another side of KK's report, looking at potential side effects from standard of care. So this is a 63-year-old man with no significant comorbidities, diagnosed with metastatic renal cell carcinoma affecting the right kidney, and has spread to T11 vertebrae and multiple pulmonary sites. Had a cytoreductive nephrectomy in December of 2015. Histology was consistent with a clear cell carcinoma, predominantly grade 2 or 3, but had focal areas of grade 4, with small areas of sarcomatoid differentiation and necrosis. So you can see the bone. This is the before. There, and there. This is the after. It's not as intense after treatment. So this is the lungs. There's the nodule there. There's one there. There's one there. And if you compare, they are not as prominent on these ones, on the base. It was staged as T1B, PN1, CNM1. Was treated with sunitinib and denosumab, December 2015. Because of side effects, they had to change the schedule. Was combined with analgesic therapy. There was disease progression documented in the lungs and spine after 4 months of on sunitinib. That was April 2016. Had radiotherapy because of pain of the back, T9 to 12. Started nivolumab May 2016. However, 14 days after nivolumab, patient had a change in behavior and uncontrollable movements. Neurological examination revealed no significant findings in his head and peripheral nerves, but there were mild generalized choreatic movements of his upper extremities and head. He was admitted to the hospital because of suspicion of a possible side effect of associated with immunotherapy. Chest, abdomen, and pelvic show signs of tumor regression in his lungs and bones. CT scan of the brain ruled out any brain lesions or infiltrative brain damage. Again, that was the same slides that I showed you earlier on, showing the regression. MRI of the brain did not show any tumor. However, MRI revealed a symmetrical, pathologically increased signal within the basal ganglia, consistent with possible inflammatory involvement of these structures. The laboratory tests for infection and autoimmune disease were negative. Similarly, the cerebrospinal fluid was negative for bacterial, viral, and malignant cells. Antiparaneoplastic antigen, MA2 IgG class antibodies were the only positive findings. And that we see there in the basal ganglia on both sides. Had a flow cytometry done because they thought that maybe this also could have been a viral meningitis. Most of the cells were CD4 helper cells. Patient was put on IV corticosteroids to manage immunotherapy side effects and had trimethoprim and sulfamethoxazole to prevent possible infectious complications. However, the choreiform movements deteriorated even while on steroids. They may had a referral to psychiatrists who prescribed haloperidol. There seemed to be partial improvement, but not much. Was treated with infliximab. There was no clinical effect, no benefit there. Patient was discharged from hospital, but a few days after, patient requested to be discharged from hospital. A few days after, was readmitted back with fever, urinary retention, and drowsiness. He was treated with antibiotics. Unfortunately, his condition deteriorated and passed away 4 days following admission. They did an autopsy, confirmed the renal cell cancer and the metastasis to the paraaortic lymph nodes. However, the ratio of the CD4 to CD8 T cells in the perivascular infiltrates localized in the frontal lobe and basal ganglia was approximately 1. Typically, it says that it has to be 3 to 1 to be aseptic meningitis. So this is just the H&E and the immunohistochemistry of the, basal ganglia and the rest of the brain. Now we look at rare cases, even though the cases I presented earlier are also rare, but they are also rare, maybe rarer cases. Because of the rarity of some of these cases, it's not possible to do a clinical trial. So what clinicians depend on are information they get from case reports and apply it to the management of the patients. So this is a 55-year-old lady presented to the oncology clinic with a mass on her thigh, 6 months duration, had radiographs of the femur that demonstrated a soft tissue shadow in the posterior thigh with some apparent calcifications within the mass. This is the mass. You can see some calcifications here. The MRI showed a large heterogeneous soft tissue tumor abutting the neurovascular structures of the posterior thigh. They did a core needle biopsy. Biopsy suggested hyalinizing tenosynovial giant cell tumor. This is the mass here. That's the mass there. Because there was a discordance between the imaging and the clinical history, they felt that it was probably a soft tissue sarcoma. So they decided to excise the tumor to have a final pathological diagnosis. However, on the day of the procedure, I guess in their practice, she was a female patient, 55. They requested for a pregnancy test that showed it to be positive. Patient reported that she was menopausal and had not had any sexual activity in nearly a year. Tumor was resected, had histopathologic evaluation, and specimen showed a proliferation of spindle cells and pleomorphic nuclei. Immunohistochemistry showed strong staining of the tumor for beta HCG, and this is the tumor, which will explain why she was having, why she had a positive pregnancy test. So the morphologic and immunophenotypic features were consistent with unclassified pleomorphic sarcoma with ectopic beta HCG production. Unfortunately, they didn't do any molecular analysis on the specimen. She received post-operative radiotherapy, and 2 weeks after that, her beta HCG test was negative. So this is the spindle-shaped cells in the tumor and the pleomorphic cells, and this is the immunohistochemistry that shows beta H staining for, highly stained for beta HCG. 1 year post-surgery, no evidence of local or metastatic disease. Beta HCG continued to be negative. This is a young child, 7 months, was referred to for vascular anomalies for the management of atypical congenital lymphedema of the right upper extremity associated with bilateral chylothorax. Had a Doppler ultrasound that ruled out any compression of the deep venous system or associated venous anomaly. An MRI showed infiltration of the subcutaneous tissue of the right upper limb without muscular or bony involvement. Lymphoscintigraphy confirmed the diagnosis of lymphedema. There was no family history of lymphedema, chylothorax, or pleural effusion. She was otherwise healthy. However, they did a genetic analysis and that showed an almost triploid genome with multiple chromosomal anomalies was detected in the biopsy. They also did a comprehensive cancer panel, but no mutation was detected. Testing for VGFR3 and FOXC2 was normal, no mutation, even using a larger lymphedema gene panel with targeted next-generation sequencing. So they treated locally with pressotherapy, lymphatic drainage, and multi-layer bandages to manage the upper limb lymphedema with good volume reduction and softening of the arm. They had a thoracic drain and low-fat diet to control the acute chylothorax. However, it recurred. But it did not prevent a recurrence. At the age of 2 years, they started sirolimus to treat, which had good response regarding the pleural effusions. 3 months after starting sirolimus, the child developed a papuloerythematous eruption on the right upper limb, which they thought at the time was due to allergic contact dermatitis because they had changed the compressive glove. But despite the treatment with corticosteroids, the skin lesions extended with appearance of red papules on the forearm and the palm. The skin biopsy confirmed the suspicion of an angiosarcoma. Sirolimus treatment was discontinued. Histopathologic examination showed ill-defined dermal tumor characterized by proliferation of undifferentiated cells with a large, irregular, atypical nucleus. Dermal tissue was infiltrated with and dissected this cell population extended throughout the dermis and the subcutis with several mitosis. Immunohistochemistry, cells express ARD D2, 40, CD31, but not CD34. The CT PET scan showed that there was extension to the thoracic and abdominal regions with suspicious inguinal node. So this is the lesion, angiosarcoma. This shows the H&E difference magnification and the immunohistochemistry showing the ARG and other things positive and the CD34 negative. Because of dissemination, they could not do an amputation of the limb, so they started doxorubicin and ifosfamide. After 3 cycles, tumor continued to progress. They tried second-line chemotherapy with vinblastine and methotrexate. Did not halt the tumor progression. Unfortunately, 8 weeks after diagnosis, the patient died of respiratory distress. This is a 77-year-old man. Again, this is another angle to look at case reports. Presented with mild intermittent right upper chest pain, 1 month duration, non-smoker, no cough, no difficulty in breathing. He wasn't vomiting blood, no weight loss, no headache, fine, apart from the upper chest pain. Nothing in the past medical history was of note. Physical examination was normal, apart from reduced breath sounds at the right upper zone. Chest X-ray showed a right middle zone lesion, and a subsequent CT scan, right thorax and liver revealed 5.8 by 5 centimeter mass in the anterior segment of the upper lobe of the right lung, aborting on the transverse fissure, infiltrating the lateral chest wall with erosion of the third rib. Also had a 2 by 1.7 enlarged right hilar node. So that's the lesion there. The rib, the erosion of the rib there, and the node there. Bronchoscopic confirmed a tumor arising from the anterior segment of the right upper lobe. Histopathology confirmed poorly differentiated non-small cell squamous cell carcinoma of the lung with marked nuclear polymorphism with no targetable mutations on further testing. Again, H&E, and this is the immunohistochemistry. Because there was no metastatic disease, he was staged as a stage 3A, and the physicians recommended radical radiation therapy with concurrent chemotherapy, which the patient declined. They also suggested palliative radiation therapy, which the patient also declined. And he opted to alter his diet, increase his intake of fruits and vegetables, and take up exercise. 3 months after, He did not have the chest pain any longer, and the CT scan showed a significant reduction in the size of the upper lobe mass, now measuring 3.8 by 5.7, but still invading the anterior wall with associated erosion of the third rib. The hilar node was still there, but size had gone down. So this is, it's not as big as it was before, and same thing as the hilar nodes compared to the previous slide. So he had serial scans done. The good thing about this person was he kept coming back to see the physicians, but he wasn't taking any treatment, and they were nice enough to see him also without taking any treatment. But 6, 9, 12 months, 18 months down the line, you can see how gradually the size of the tumor, lymph node, everything went down. And the most recent scan of the thorax and liver at 24 months after diagnosis shows a stable focus of soft tissue density at the site of the primary tumor with associated scarring of the adjacent lung parenchyma and tethering of the adjacent pleura and sclerotic changes at the right anterior lip. No enlarged hilar nodes and no other lymphadenopathy or metastasis. So over a 2-year period, he decided to do his own thing, and he's doing well. So this is it. So there's hardly anything there. Hardly anything, probably some sclerosis of the rib, and the lymph node is almost disappeared. Unfortunately, they didn't tell us what he took. They just said he exercised, he took fruit and vegetables, and his diet, but they didn't say specifically what he did. Again, this is another perspective of hepatocellular cancer in a child that had transplant, multivisceral transplantation. Born prematurely with gastroschisis, which is the anterior wall of the abdomen did not close, so the organs were outside when the baby was born. As a result of that, they had to resect the bowel, and because they resected a significant part of the bowel, the gut was short, so the baby had to depend on total parenteral nutrition. But TPN also has its complications. As a result of that, the baby developed cholestatic liver disease that progressed to cirrhosis, severe portal hypertension, and subsequent decompensation with coagulopathy. 8 months, she had a transplant of the liver, small bowel, pancreas, and the spleen from a donor that was 3 years, healthy female who died from a head trauma. The donor was negative for hepatitis A, B, C, however, was positive for EB virus IgG. The HLA cross-match was also negative. Surgery was complicated. Again, patient will receive tacrolimus and prednisone immunosuppressive therapy. 2 months post-transplant, she developed EBV viremia. Like I said earlier on, that was the only thing that was positive in the donor organ. This was managed by reducing immunosuppression and giving ganciclovir. Developed some mild rejection. They had to increase the immunosuppressive therapy again. EBV viremia recurred, and 3 months after the transplant, she developed post-transplant lymphoproliferative disease that was confirmed histologically by biopsy of the inguinal and the axillary lymph nodes. However, clinical condition improved on tacrolimus and rituximab. She had a graft dysfunction leading to 8 ileoscopies and biopsies over a period of 4 months. At 3 years, she was found to have a multifocal post-transplant EBV-associated smooth muscle tumor in the small bowel and mesentery. Again, confirmed by biopsy. Tumors were determined to be unresponsive to standard chemotherapy, radiation, or surgical resection. Patient was enrolled at Sloan Kettering in New York in a study that gave several genetically modified EBV-specific cytotoxic T lymphocytes in addition to vorinostat as part of the restart protocol. Patient was clinically stable with good liver and small bowel function. However, the EBV-associated tumor was progressive. Remained at home without need for frequent hospitalizations over a period of 4 years. Six years after transplantation, routine scan to monitor the smooth muscle tumor progression showed a new hypervascular mass in the patient's liver. MRI confirmed a hepatic tumor with multiple hypervascular foci unchanged from the prior CT. Patient continued to do well, stable. However, the liver lesion increased in size. Biopsy confirmed hepatocellular carcinoma, clear cell variant. She underwent a left hepatic lobectomy with clear resection margins, size 11.7 by 9.3 by 8.2 centimeters. The residual liver contained multipotent yellow nodules ranging from 0.3 by 0.3 to 1.5 by 0.9 to 0.6 centimeters. And that's what was removed from the liver. Patient was discharged 11 days after surgery, was stable. However, the AFP was 211 nanograms per mil, which showed that he had recurrent disease. However, the family decided that they would not go with further treatment. They went for comfort care, and the patient unfortunately passed away 6 months after. So, our case reports important in this era of evidence-based medicine. Some people think that it's a waste of time, that there is not much we can get from case reports. Albert and his colleagues looked at 100 published case reports in Archives of Dermatology. Some of the issues they found were that there was publication bias in support of positive results, exaggerated claims of efficacy and safety, inadequate informed consent reporting, underreporting of patient-centered outcomes. Some of the challenges of case report is that because it negatively impacts the impact factor, it creates a dilemma for journal editors. The other problem is that a high impact factor may make a decision as to where an author chooses to submit their work, and also companies determine the allocation of their advertising budgets because they want to put money in journals that have higher visibility. Evidence-based medicine is concerned with finding the best evidence for clinical decisions. For example, should we apply a particular therapy or diagnosis test to a particular patient? However, case reports have other aims that are equally important in the progress of medical science and education. Meta-analysis or systemic reviews of case and case series. Mayfield and Gorin looked at 21 cases, tamoxifen-related ocular toxicity in breast cancer patients. As a result of that review, they found that they recognized the difficulty of attributing ocular findings to tamoxifen and other competing causes of retinal, macular, and corneal abnormalities. It also gave them a clearer picture of the nature and distribution of the toxicity as well as severity of the ocular findings. Norden conducted 20-year literature review of both case series and case reports of carcinoma of the fallopian tube. At the time, they were able to describe more patient characteristics, the causes of treatment failure, and the absence of controlled trials, and usefulness of a second-look laparotomy for monitoring disease response to the treatment given. We looked at herbal case reports in cancer patients. When we did it in 2011, there were 18 case reports with apparent anti-tumor effect, 21 cases with toxic effects. At the time, some of the clinical trials were found in green tea, phytoestrogens, mistletoe, Ganoderma lucidum, noni, and silymarin. Some other cases, intervention had been studied like saw palmetto, PC spares. However, what we found was that many of the herbs with promising case report findings have either not yet been explored or the results have not been reported in English. So we know from case reports, meta-analysis, that it's only the characteristics and case outcomes can be better assessed at this level of research. However, in situations where there is no other adequate evidence, the best of the first line of evidence must be taken into account. What impact has case report on medical research? The only thing I want you to concentrate here is just here looking at case reports that were followed by published trials. Only 17%, 83%, were not followed. Now, when we look at case series, the number is higher, 31% and 69%. So how do you write a good case report? Nice, good title must be clear, keywords, abstract. These are the care guidelines. Introduction, patient information, clinical findings, timeline, diagnostic assessment, therapeutic intervention, follow-up and outcomes discussion, patient perspective, and informed consent. Most of the case reports that you see now, most of them probably will not contain patient perspective, but some of them do. And so, conclusion, we need to write case reports in an organized and structured manner. I believe it's still strongly relevant in present-day medicine. In fact, there are more case reports now than there were several years ago. There are some journals that are specifically dedicated to case reports. And in rare instances where clinical trials are not possible for ethical reasons or other reasons, case reports or series may be the only evidence available to recommend treatment. Thank you, and I thank my colleagues. And any questions? We made it before 6. Thank you very much. I told you it was simple.